So welcome to week 5. Literally, we're halfway through this course because week 11 is your HESI. So you're halfway through all the information. Today is cardiac and respiratory. Now, actually, cardiac is my strongest of all of the diseases, I would say, in pediatrics. I worked 10 years in the cardiac intensive care unit and actually opened it when a surgeon came, and it became internationally renowned hospital center for cardiac care on the children. And we know congenital heart defects are newborns. So a lot of newborns that I take care of. Kristen and Yesenia Mendez, come on camera for me, please. Thank you so much. So we'll do that first, and then we're going to be doing our cahoots. And it is a longer cahoots, so it is a longer day. We're going to run right till about 5:15 today. Remember, you have 2 case studies, congenital heart disease, they're open and ready for you, and cystic fibrosis, they're due next week. But I have them open this week so that you can start them. So they're there for you. We will be taking a quiz. It is on this week's information. So listen carefully. And then, of course, your discussion question number 4. I did grade all your discussion questions. The one thing that I found most of all was that you're not doing any in the paragraph, in the body of the paragraph, in cite text, which means, let's say you just use your book, Perry et al. Should be in parenthesis marks with the name of the author, comma, and the date it was copyrighted, 2023. Just in parentheses, Perry et al, comma, 2023. Put at the end of a sentence somewhere. That is a citation. And instead of an 18, you're going to get a 20. All right. And as you move forward for your BSN, MSN, they're going to get really particular on it. So that's why I mention it to you. Because when I went back to school, I had never written a paper. You know, I didn't go back to school to 2007. I had been an RN for 33 years. I went on for my BSN, MSN, and my PhD. Now, I didn't understand APA at all, so I had to learn it from the ground up. So I'm just trying to get you ready, prepared. I do give you a lot of leeway in your APA format because it is your first time really using it. But as you go forward, it's going to get stricter, okay? So that's just a hint for you to use. Okay, so we know what we're going to do this week. We know what's that you need to do. And let's start out with our PowerPoint. Remember, anytime during this you're not getting it, please stop me, okay? So this is, as I said, it's cardiac respiratory. We start out with respiratory, all about the lungs. But remember, the lungs respiratory is also connected to all of the mucus in your nose, your ears, your tonsils, you know, and all of those conditions too, all related to respiratory. So that's all your upper, you know, your common colds. That is your, you know, strep throats, pharyngitis. That's your earaches, okay? And then the lower, we mostly consider more of a bronchitis or your pneumonias. Now, most of your upper respiratory are going to be viruses. I mean, those of you who have children, you run to the doctor because your child has a fever of 104 and you need to get antibiotics right now. And the doctor says, no, they might do a flu test or a strep test that's negative. And they're going to say, no, we're going to send you home on just taking acetaminophen, ibuprofen, and try to get liquids into your child. And you're like, but the fever is so high. Well, virus fevers are always high. So it usually goes, you know, for say. Now, when you get into the infectious type things like strep, your fevers and pneumonias for sure. You're going to see fevers usually, and this is my experience. This is not in a book. It's not an exam. It's just for those who are parents, 101, 102. Those are the temperatures that you see with pneumonias, that you see with those bacterial infections. So those elevated ones, They're not going to be bacterial. They're mostly viral, just to let you know that. Now, we know newborns are born. They come with mommy's antibodies, but you know, they don't last. They're going to go away. And we're going to be given immunizations 2, 4, 6, 12 months, 15, 18, 2 years. I mean, they get a whole bunch of these immunizations. And these immunizations are to treat those very difficult to treat conditions, pertussis, diphtheria. You know, we don't want our children to get those because, you know, especially the young kids, you know, a lot of them don't make it through those illnesses. So, but your child's going to get some little viral, upper respiratory, you know, a lot of nasal mucus, ear infections. Usually we see that as mom stuff goes away, between 3 to 6 months, you're going to start seeing an increase in infections. And as I said, mostly are going to be upper airway, mucus, and then of course, a lot of earaches. That mucus goes right into those ear canals because it's so wide open and straight. It's just an easy pathway to go. It's the way of less resistance, okay? Now, as we get older, remember I told you toddlers are the kids that all they do is they go to daycare and they swap spit, which means one kid has a toy, that toy goes to the next kid, and they're just sucking on each other's mucus. And you're like, but you know, maybe they should clean it in between. Well, how is a child going to build up an immune system? So this is one of the ways they do that. You know, once we get an infection, your body gets antibodies, builds it up, and it becomes, you know, become more resistant to getting those illnesses. By the time they get into kindergarten, it's usually just your bacterial type of infections because you've gone through the gamut of all those ear infections. And we know as we get older and we get these little colds and upper respiratories and all of these infections, the body now has made defenses, so we have an increased immunity as we get older. Now, as I said, the children, the diameters are smaller, shorter, wide open, and that's why mucus from the nose is going to go right up into the ears. And inner ear, even in the externas, hurt really bad. So usually they come in and they're screaming in pain. Now, what does a kid look like? Comes in with an upper respiratory problem. It's, you know, depends on how old they are, but some of the things that you will see is you might or might not see a fever. And if sometimes the fever is low grade, sometimes, you know, they're, as I said, 104. And we know probably they're going to be viral things. But the one thing a kid will do, especially if they're getting to be older, as in 1 year old and more, they're going to stop eating. That's one of the big clues. My kid stopped eating and my kid eats like a horse. And listen to that parent. Something's wrong. Go looking for it. Sometimes you might see vomiting, diarrhea, or abdominal pain, but not always. You might see a cough. You might see nasal mucus, but sometimes it's just a low-grade fever and stop eating. And what do children do is they just sit down or lay on a couch and fall asleep. Well, that's just not normal. That kid's usually running at 100 miles a minute, especially toddlers. That's what they do. I mean, you might be able to hear, you know, that mucus rattling in the chest or wheezing, but sometimes it's very subtle. Now, respiratory conditions. What is our goal? What do we want to happen once they're treated? Well, we want them to breathe easier. We want them to rest, and they want them to be comfortable. We don't want them to get that infection everywhere, so we want to try to clear up that nasal mucus, right? Because that's how it gets everywhere. And of course, as they get older, teaching children, and of course, the children around them and adults, washing hands, you know, and of course, coughing the right way as they get older. We want to keep the temperature down. And it's not because the temperature is dangerous. We want to reduce the temperature because the kid will feel better. Once that fever comes down, that kid's going to eat and drink and run around. And you want a child who is sick, especially with upper respiratory, to drink. It loosens secretions and it gets it out easier, right? So that's why we promote hydration, nutrition through reducing their temperature. And of course, need their hugs because children who are sick, that's what they think is going to cure them, a mommy hug or a nana hug in my case. Now, otitis media, I've talked about ear pains. We know it's because of those little short, open tubes that'll lead it right into the ears. And it's because many kids can't blow their nose, right? They don't know how. And we don't have these great suction machines at home. I mean, you could go to the local drugstore and get these air Frida things and you can get it out, but it's not that strong, especially if it's really thick. So, and kids, they didn't learn how to blow their noses out yet. So it's going to go up there. Now, how do we treat an ear infection? Well, number one priority in nursing care, when you see that kid initially, is give them something for pain. Pain is huge. The kid comes holding their head. An infant will be banging their head. They'll be swishing it against, and you'll see them grimacing, and you'll see that little chin quivering. Get rid of that pain. Because once the pain is down, then the doctor comes in and visits the child, does an examination. They'll be able to look in the ear and they go, oh, that eardrum is bulging. Okay, definitely an ear infection. So first thing is give them pain, something for pain. Honestly, what I have seen is ibuprofen works great because it's an anti-inflammatory. Although Tylenol in your younger kids work just as well. But I personally, this is just me, I prefer ibuprofen because, as I said, anti-inflammatory. Now, how do we treat otitis media? Well, if it's just an occurrence once a year, twice a year, we're going to be giving those antibiotics. We start out with an easy one, just simple amoxicillin. The one thing about teaching now, parents, is to make sure they take the entire dosage. If it's 10 days, they should get it for 10 days. You know, don't after 5 days, the kid is fine, stop. And it's such a pain to give it to them. So, and that's what happens. I can't give the kid, he doesn't want it. And, 5 days is good enough. Well, you could have a reoccurrence, okay? And then you keep reoccurring. And now you can affect hearing on these children. If it's constantly reoccurring, the physician might decide to put tubes in their ears. A lot of times you'll see tonsils, adenoids, and tubes all at the same time because they figure they're all interrelated. So many times you do see that. So giving them something for pain, teaching them how to take all their antibiotics can really help with that reoccurrence. Another thing I tell them is to, when they're in bed, the older kids, not the younger ones, I put a pillow, raise their head up a little bit. Ever have an ear pain, you lay straight down, the ears pull back, and it is miserable. You sit them up, they'll go to sleep, and it doesn't pull back the same, and the child will get rest. A kid who doesn't sleep is a miserable child. Now, infectious mononucleosis, we've heard about this, right? This is the kissing disease. This is drinking somebody else's cup of water, juice, whatever, and it's a virus. It's a herpes-like Epstein-Barr virus. So no big deal, right? Well, what do you feel? Well, you feel lethargic and tired. It's called extreme fatigue. You do run a fever with this. You have a sore throat, and because you got fever, you have head and body aches. And you'll see swollen lymph nodes on these children, but you'll also see the liver and the spleen both swollen also. Now, let me tell you the process of events that happens with infectious mono. It's not easy to diagnose. Child goes to the doctors complaining of fever, sore throat, not feeling well. They do a strep test, maybe a flu test, and it's negative. They send them home and said it's a virus, Tylenol or Motrin. 3 days later, the kid still feels horrible. Bring them back into the doctor's office or urgent care. Sometimes they go next. And they'll say, okay, well, it's not that, well, let's try some antibiotics. So they'll put them on an antibiotic. Well, 3 more days later, the kid is still sick, feeling horrible. That's usually when they go to the emergency room. They come into the emergency room, they say what they've done, they treated it as virus, they gave antibiotics, still feel horrible. So what are we going to do? Well, we have to prove that it's not a bacteria. So we do a CBC. Are the white counts elevated or not? If they're not elevated, it's a virus. So, okay, it is a virus. but we're going to do something called a mono spot test. And many times these children, it comes back positive. How do we treat mononucleosis? Now we know what it is. We have a name. Well, it's still a virus. It's Tylenol and Motrin, liquids, plenty of sleep, right? But didn't I just say the liver and the spleen were both swollen? Now, let me tell you a story so you'll never forget. I was in the ER on a Saturday morning, and a father brought in his son. He was 8 or 9 years old. Went through exactly what I just said, the scenario, just like that. We did the labs. CBC was normal, monospot test positive. Now, that day I was working with a really good physician, and he gives great discharge orders, and instructions. Made it clear, avoid contact sports. If you have other children in the house, no roughhousing, no touching that belly, protect that abdomen, because the spleen and the liver are, very distended and they can burst and it could cause major problems. Well, 1 week later, I am now the primary trauma nurse. So if any trauma comes in, a helicopter comes in, I am in charge. I'm the primary. Kid was in Everglades on a trike, fell off, hit his abdomen on a rock, came in, and they were doing CPR. Got him there, he was pronounced dead. He was that kid who had mononucleosis, who was out in the Everglades, who fell off a trike, where he was told no contact sports, protect that abdomen, just rest. And he couldn't do it for at least 3 weeks. No PE in school, he had instructions. I went behind the physician, this child, this father, and the kid died. And it's sad to this day, I'll never forget this child. And I use him as an example to let you know that kissing disease can be a big problem. So teaching, no contact sports, restricted exercise, is so important, because the spleen or the liver can burst and there's nothing you can do. Okay, ever hear of croup? Croup is a seal-like bark. It is called laryngeal bronchitis. It's basically the larynx is inflamed and it's swollen and it's causing this big barking cough. Now, this is inspiratory stridor because you can't get the air in. Remember this, because there's a difference between inspiratory and expiratory. So inspiratory stridor, croup, and a terrible bark. Now, usually these children come in and we'll give them a dose of steroids, whether a pill, whether a shot, or we'll give them a couple days of steroids to treat them, and they do well. Many parents are like, it's just a dry cough, there's really no fever, and they let it go. Well, problems can occur. Well, let's start now with another thing in the lungs called bronchitis, tracheal bronchitis. Now, ever have bronchitis? You have a cough, and it's like worse at night, and you can't sleep, and nothing comes up. It's just this cough, and you can't sleep. So it is a virus. Usually, though, you might see these treated with usually azithromycin. The doctors will put them on there, especially if they have a little fever, depending on their status, whether they're a premature infant, etc. Usually they'll put them on something. But we'll treat them with acetaminophen, ibuprofen for discomfort, plus you're coughing like crazy. My chest would hurt horribly. Humidity, and something to suppress that cough. Usually a narcotic cough medicine on the older kids. Younger kids, no, but older kids, they can put them on some sort of cough suppressant. Although if you ever try to get a cough syrup today, nobody has them. I guess they stopped making them because it was abused. So children who have bronchitis, adults who have bronchitis today can't get a cough medicine. It's not out there. So bronchitis, the key thing is a dry, hacking cough, non-productive, worse at night. Now, acute laryngeal bronchitis, tracheal bronchitis, again, this is your croup. As I said, we treat this with a steroid. Now, we will usually think that a croup child has had some sort of upper respiratory, you know, that little mucus going on, a little cough, and it progressively got worse to you're coughing like a seal. And let me tell you, you can hear a croup across the room, across an entire ER, and if it's noisy, you can still hear a croup child. Again, inspiratory stridor. Now, if we allow this to go on and don't give that steroid to decrease the swelling in the airway, it can lead to respiratory failure. Now, what happens is the epiglottis is, do you know what an epiglottis is? It's that leaf-like structure that covers the trachea when you swallow, so food don't go in the lungs and cause an aspiration pneumonia. Well, in acute epiglottitis, remember, you're coughing, 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 and this is the area, upper airway, where this irritation's coming from. And the coughing causes more irritation, more swelling, more swelling. The epiglottis covers the trachea, and you cannot breathe in. You can push air out because it pushes that epiglottis away, but in you can't. So if you can imagine, they sort of try to move around and try to find a way, usually tripod, just like the older patients with chronic obstructive pulmonary disease. They'll lean forward, put their hands out, and they'll lean forward. And there might be one little position where they can get a little air in, okay? This is a medical emergency. They're not getting air in. There's no opening. Air can't go. You're going to see a kid that can't swallow. They're drooling. And your voice is going to be, I mean, that's about what you'll hear. And you don't want them to talk because it will create more irritation down there. And because they can't breathe in, you're going to see all the retractions. You're going to see suprasternal, substernal, supraclavicular. I mean, these kids are working hard. Now, you get a kid in, suspected epiglottitis, nursing priority. Remember, you can't breathe. There's not an airway. You want an airway there available in case they can't breathe by themselves, which means you're going to put them in an area where there is a tracheostomy tray, which we can put a trach in right away, or to intubate them. And it usually is the trach because there's no hole to stick those endotracheal tubes in. The epiglottis is in the way. Can you imagine? So these children are, your emergency. Usually you have a whole room full of people helping these kids. So we're going to maintain that airway. Whichever way that kid wants to sit, you let them sit until we can get an IV in them, get some steroids in them, get a nebulizer on, and the nebulizer, we put epinephrine. It's called racemic epinephrine. We put it like albuterol, like a regular aerosol. There is racemic epi. We put it on, and that will help. Goes right to the site and helps stop the swelling. Plus the IV solumedrol steroid will help also. And then we'll put them on supplemental oxygen, usually a mask with humidity in it, because that moisture also helps them breathe. So epiglottitis is big. Think about drooling. Think about a kid with that inspiratory stridor. Okay. Ever hear about RSV? You've heard that usually with young children. RSV is also called bronchiolitis. It's the same thing. It's a different name, but it's the same thing. For you and me, this is a common cold. And what it is their noses get full with mucus. You have a low-grade fever. And infants have a hard enough time sucking, swallowing, and breathing. Furthermore, they're obligatory nose breathers. So if their nose is full of mucus, they can't breathe. So now they're struggling to eat. They're tiring out easy. They're probably getting restless and hypoxic because they can't breathe when they're feeding, right? So, well, what if you were a premature infant or a cardiac child or some other of these immunosuppressed conditions? We can't keep that going on because this kid will end up coding and dying from respiratory distress because of this nose that's all blocked up. So there is a monthly immunization, and it's called Synagist. The other name, the generic, is palivizumab. It's one of those biologic things. It's, to treat the virus and to stop them from getting it. We give it from usually winter, late fall, winter. This is now the weather changing, right? From cooler now to cold, and then early spring. Now we're going cold to warm. Those changes in temperatures do cause them to have it. As a nurse, what do? Well, we want to suction out that airway, but not too much because you can overstimulate, and then you're going to get more mucus. Also, with the RSV, sometimes these kids, when you suction them out, they'll be able to eat. Some of them can't. And those children will be with an IV to get their fluids that they do need. These children, if we can feed them by mouth, we'll just take our time, slow and easy. And they can. Many of these are diagnosed and parents can feed them. They know how to suction the nose, we'll send them home. Doesn't mean all of these are sent into the hospital. A lot of these can go home, but of course, many do stay in the hospital because they're so full and they're not breathing. And we have to maintain that oxygen saturation. So our goal, again, maintaining that airway, keeping them hydrated, put on that misty oxygen, again, loosens secretions, suction it, usually before they eat. We don't try to do it too much. Again, it stimulates more. And again, we're going to do those epi and steroids with these kids. Same thing with them, depending on severity. Now, tonsillectomy. Anybody get a tonsillectomy as a kid? I was 20 years old when I had a tonsillectomy. I was having chronic throat infections and chronic, inflammation. So they had it. Let me tell you, it was horrible. When I woke up, it was like your throat was like raw. I wish I knew some of these instructions for older children that could have really helped me. Now, they go to the OR just like prepping any child or any adult for OR. They come back and now we have to teach them. Most of these are sent home right after surgery today. They're not kept in the hospital. It's an in and out procedure. Usually it's tonsils and adenoids, and sometimes it's the ears too, remember? So they cannot eat any irritating or highly seasoned food. This is orange juice or anything spicy. My brother, when he was young, my mom said he wanted radishes with salt on it. And she called the doctor and he said, whatever he wants, give it to him. And he had radishes with salt, which is bizarre. You shouldn't. But the salt was good for him, right? No gargling and no vigorous toothbrushing. Leave that area alone. If you can imagine, there's no sutures. All they do is cut these things out and there's a scab left. And that scab can come off and you can bleed and hemorrhage from that area. I've seen it once. And it was clots, blood clots and bleeding. And a child who, was starting, her blood pressure was going down and her heart rate was going up. And a 6-year-old, I was giving a whole liter of normal saline. I mean, it could be dangerous, tonsillectomies. So no coughing, clearing the throat. And you wouldn't give a straw for these kids to drink because it puts extra pressure in the back of the throat. They used to give more narcotics, but today we, Tylenol and Motrin works really well. They don't need anything more than that because they were finding some of these kids were overdosing. The parents gave them too much. So we're not, we don't recommend it anymore. An ice collar, something with an ice bag right at the neck actually helps in the soothing. Also, these kids shouldn't be up and running around and jumping and going to the playground. At least for 1 week after surgery. No. The kid that hemorrhaged on me was 7 days post-op, had just come from the doctor's office. So yeah, it can happen that late. And the one thing that I wish I knew about is chewing gum, because your ears start to bulge and hurt. And it's like, why do my ears hurt? I had my tonsils done. Well, it's where the eustachian tubes are. So it did hurt. So chewing gum, ice bags, and one thing that these children wake up and their mouth is dry from that anti-cholinergic drug like atropine that they got, and it hurts and they want something to recommend ice chips first. Okay, a couple ice chips, see how they do with that, and then go further. There is odor because there's dry blood in the mouth, but it shouldn't last over 10 days, just like these earaches shouldn't last more than that. And if it does, you need to go back to the doctor. And then usually they will get them into some sort of clearance to go, their regular routines. Pneumonias. Now, as I said, pneumonias, temperatures 101, 102. You'll maybe hear a cough, vomited once, and they stopped eating. That's probably the most common symptoms that I have seen. Now, there's many ways to get pneumonias. We're going to go into that. It can be bacterial, viral, mycoplasma, pneumococcal, and that's why we have that vaccine today. We don't want kids to get a pneumococcal pneumonia because it's very difficult to treat, and it's also very dangerous for these, especially younger children. And mycoplasma, they'll be on double antibiotics. So depending, it could be more severe. Pertussis. Now, we did get pertussis as 2, 4, 6 months, didn't we? Part of the vaccines. Well, right before I left, working in the hospital, the ER is always, and I was working in the ER then for the last 10 years. And these children were going into the county up from us. And we got report that pertussis was back in town. And pertussis, you'd see a high fever and you'd see a cough. The thing is, it is highly, highly contagious. That's why you always ask, is your child immunized? Very important. I mean, remember, I'm immunosuppressed. I never got strep throat and all those things because when I heard what was going on, I either wore a mask or I made sure I washed my hands and wore gloves. And I protected myself, and I was susceptible to everything. So if I could not get those things, normal immune system should be able to fight them off. But pertussis is very rough to cure. It's antibiotics, especially those younger children. And because it's all airborne, these children will be placed in a reverse flow airflow, again, where the air can't go back in the hospital. It goes out because it can be in the environment through the air. Now, these are pictures actually that I had on one of my kids. Foreign bodies. What do kids do? How do they explore the world? In their mouths, right? Well, you'll see all sorts of things that kids swallow. Beads, paper clips, any little small cars. I've heard backs of earrings, anything they can find. Hot dogs, that's why you should cut them in irregular tiny pieces so that they don't inhale them. I actually saw a French fry go into a 3-year-old's windpipe, clogged it up. He ended up on ECMO, and 3 days later, he died on a French fry. It was, and it wasn't due to neglect, it's just he aspirated a French fry. Now, one of the most common is coins, okay? And it's not a dime or a penny, it's a quarter, the biggest of all the coins. And today, how do we diagnose this? Well, usually they say they have pain here, and usually they're drooling. Not necessarily coughing because it's in the esophagus. We send them to a radiology, we get an x-ray, and there it is, stuck right there. So how do you think we get that out? Well, years ago, we did a bronchoscopy, start an IV, get to the OR, put them out under anesthesia, go in with little bronchoscopy tube, little tweezers, go in and clamp it and bring it out. Overnight stay for observation. Today, they're wide awake, sitting in a surgeon's lap. Parents are there, I'm there, I'm saying, and when the coin comes out, I'm getting it first. If you're not down there first on the floor, I'm gonna grab it. We take a Foley catheter, put it down the mouth, below where that quarter is, blow up the Foley balloon. Now we've got a big wide area, right? Lean them forward, we tell them to cough, and we pull it. They will vomit and vomit up the coin. And I'm like, the coin's mine. And what does a kid do? He goes right on the floor to get it. Well, what did I actually do? I distracted him from what just happened, didn't I? And now it's like I got the coin and I won. We'll watch him an hour or two, make sure his airway's okay, send him home. And that's the end of that. Aspiration pneumonia. You know, I love Johnson & Johnson baby powder. I think that smell is awesome, but the powder in the air can cause them to aspirate it and it can damage the lungs. So today we don't use powder at all. In fact, nobody should use it because of that aspiration. And that actually makes me sad because I love the smell of it. Another way we can aspirate is feeding. You know, you have these kids with reflux that they're burp and they'll puke a little bit. Sometimes they'll inhale it back into their lungs. It's just aspiration pneumonia. So we need to teach parents how to feed a baby, how to maybe put something in it to thicken it, to hold it down. That's when we use like a little bit of rice cereal. Actually, it's 5 mL of cereal to 1 ounce of formula or milk, and that will be thick enough to hold the food down so they don't keep losing their nutrition by their vomiting. Another thing is to burp them well after they eat, also to sit them up for a good half hour and not to overfeed them. I think parents think that they're crying, they want more to eat. Well, sometimes yes, but if you have a reflux baby, you should wait a little bit to make sure that they don't vomit it up. And then of course, aspirate. Now, cystic fibrosis. Cystic fibrosis is twofold. It is the lungs clogged with mucus and the small intestines doesn't have the ability to digest food the way it should because of the pancreas, and the child's not getting nutrition. What do you see with these kids? Well, if we catch it at birth, this is a kid who is doesn't have a bowel movement in like 2 days after birth, because every newborn has a stool within the first 2 days. Well, if the child doesn't, they'll be checking for cystic fibrosis. It's one of the signs of that as a newborn. You're going to see a kid who's coughing. Now, their lungs get full of mucus. They can't expectorate it. And the lungs are producing this thick, thick mucus. I call the lungs a petri dish. It's a place where bacteria goes and multiplies. That's, the only way I think that you could describe it well. So all your lungs are, wheezing, coughing, and you're going to hear decreased sounds. The other thing is because you're not digesting food, you're going to have these very foul smelling, greasy stools. You're not digesting fat, they stink, and these kids are not gaining weight because why? They're not getting all their nutrition. So what do we do? What's the treatment? Well, number one, you need to diagnose it. Now, if you have an infant you think has cystic fibrosis, if you licked them, you would taste salt. Now, I'm never going to tell you to lick an infant, okay? But if the parent licked their child, they would taste salt. They lose salt like crazy. So this is never a sodium restricted kid. They're losing salt, okay? So now you're diagnosed. So, all right, remember you got lungs that are petri dishes. So antibiotics are going to be used all the time. We're also going to use medicine to try to thicken up all of that secretion so they can get it out. Get rid of that petri dish, get it out. And it keeps the airway open and decreases chances of infection. Then there's all sorts of chest physiotherapy. Ever see those chest vests that they put on that vibrate? Well, those things on many kids are at least twice a day they use to try to help get them up. Now, that's all about the chest. Activity, swimming is a great thing for them. Getting them moving, exercising, important because it makes them breathe deep. Now we're going to talk about the small intestines. Now, how do we treat this problem with nutrition and the inability to digest food? Well, the child has a pancreatic insufficiency, and we need to give them medicine before meals and snacks. And usually the name is pancreatase. And what we do is we give, as I said before, meals and snacks. It comes in powders. It comes in these little capsules with these little beads. Well, number one, you never, ever chew or crush these sort of enteric-coated beads or any enteric-coated medicine. We just don't do that. So what we do is the dose is there for the kid. You can sprinkle it like maybe they're eating applesauce. I mean, an infant, it might be using powder in their formulas, okay? Now, the one thing they say is that once you give these medicines, make sure you, if there's teeth, to wipe their gums. The younger kids, just a wet washcloth. Just make sure you clean their mouth. The older kids, you'd have them brush their teeth after you're giving these things, or at least swish and swallow, swish and spit out their mouths after they eat all the time. And the one thing we forget in many medicines is as a child grows, increase the dose. Now that is a question that you're going to see on your NCLEX questions about CF. Right there is your answers. Now another question that comes up about cystic fibrosis is pregnancy. Now women can, yes, they can get pregnant, but it's very difficult to get pregnant and there's many complications. Men cannot, have a baby. They don't have the sperm. It doesn't deliver. Something to do with vas deferens and deliveries. And I'm not really completely sure about it. But if a person wants to have a child with cystic fibrosis, if they get a bilateral lung transplant, they can have a baby about a year after. So many men go through it to get it there. And depending on the woman might do it also, but absolutely the men will have to do it to have a baby. Now, acute respiratory distress syndrome, ARDS. This is something happens when the lungs shut down. It could be due to trauma, could be due to overwhelming sepsis. And sepsis is the biggest thing that you do see with children. Children don't have that immune system, so they sepsis tends to be the one thing that causes their whole bodies to shut down. Well, what if you were in a car accident? Okay, that car accident in the chest can cause problems. The adolescents, drug overdoses can cause it. And then when you have these near drownings, near drownings can create a problem up to 72 hours later because of the hypoxic incident of the water in the lungs, and the body all of a sudden just doesn't want to behave anymore. And this kid is sick. Look at these machines that are here. This is ECMO, they can't move. They're on all sorts of vasopressors, dopamine, dobutamine, epinephrine, Levophed. They're paralyzed, sedated. They're getting respiratory treatments to open their lungs. They have a machine trying to oxygenate them. These kids are sick if they make it, okay? These kids are very ill. CPR, well, we all had to take CPR, right? We know what to do. Well, what we do with the parents when their child is having a cardiac arrest. Okay, that's the big deal here. Now, years ago, remember I've been a nurse now for how many years? 46, 8, I don't know, long time. More than most of you are old, and I've loved every moment of it. But we used to send the parents out. Yeah, we didn't want them there. But if you can imagine, if you're a parent and your child is having a cardiac arrest, don't you want them to be there, at least to talk to them, hold their hand, or to remember that everything that was done, that they did everything to try. Now, sometimes the rooms are too small and they can't, and that's something else. But make sure you have somebody there talking to those parents. It is scary. Let them know what's going on. Because many times we know cardiac arrest, you don't have good outcomes. Okay, asthma. Have any of you had asthma? I'm sure a lot of you do. if you have a child that you're hearing wheezing, and they've never had asthma before, but if you hear wheezing, you always try to rule out asthma #1, because that's usually the most serious of all upper respiratory infections, because now their lungs are clamping down. They can go into severe bronchospasms. We know asthma is a bronchial hyperresponsiveness. It's usually due to something. Cats, dogs, grass, it could be leaves, it could be dust, it could be bed dander, all different things. So finding out what happened and why it's happening are our goal. And then getting them on a routine to prevent them from having asthma attacks. So you have a child, had an asthma attack, now you get them up feeling a little better. You're going to look at their lungs, pulmonary function tests. You're going to check them for all these antigens, these allergies. What is causing it? And then if we need to, get rid of the dog or the cat, or maybe put protectors on the pillows and get rid of rugs or curtains or whatever it is. That's especially those who are extremely hypersensitive. So in children, our goal is always to get them normal. Now, if you're allergic to grass, this kid shouldn't be playing baseball or soccer, right? Or football, but they can be on the bowling team, the tennis team. There's other swimming. There's other stuff that they can do until we get those allergens under control. Now, those little things down there, the orange, pink, and blue, these are great. These are little spacers. Kids can't push it in and inhale at the same time. Well, many adults can't do it either. So we have them adult size too. And you'll see even smallest kids, like this little guy, will push it and breathe it in and out. They're not scared of it. Again, letting them touch it, play it, get on their level, they'll be cool. Now, long-term treatment of asthma. So we've done the pulmonary functions, we've done allergies, we know what's going on, and now we need to do daily treatment. Well, we need the preventative medicines, which is given morning and night, twice a day. The adult world, you see Symbicort, Advair, Brio. It's an inhaler, usually a puffer, that is slight little steroid in it, so it prevents. Albuterol is rescue. When you're wheezing, you can't breathe, it's always the albuterol, the Ventil, or whatever your name is for those, but usually those two. They also are going to be getting Singulair at night. It's like a Claritin, but it is directed towards the lungs, and it's called Singulair. Now, when we get an asthma attack, they'll be placed on steroids, decrease that inflammation, because that's what the wheezing is. And this cromolyn sodium, that's usually what we call Atrovent, which again is that steroid type of thing. And we'll be giving albuterols to this kid, opens up and can breathe, and we can hear air moving. Now, cardiovascular. Now, think of the heart and all of the vessels as a garden hose. And think about when you kink a hose, everything goes backwards. And where can the blood go? It goes to least resistance, right? So remember that as we start here. And if you're not following me anywhere, stop me. So we have two types of cardiac defects. And many of them, they're born with them. Fetal circulation, I'm surprised there's not more hearts that are not, with some sort of congenital heart defect. What it goes through, during fetal gestation is incredible. It's a stalk that turns, it comes up and each other and twists and, rotates. It's incredible. But normal hearts are most of us, and we're lucky. Then we have acquired, could be an infection, usually viral. You'll see a viral myocarditis, big, stretchy, floppy heart that don't work well. Could be autoimmune. Any of you have lupus? Well, lupus attacks organs, right? That's one of them. Environmental, it could be, the air you breathe with chemicals, or it could be familiar. It was passed down. So let's look at this little drawing here. I'm going to right now give you a drop of blood, and I'm going to go through the heart. You need to know where it goes in order to understand where the blood goes if there's a kink or if there's not an opening somewhere, okay? So let's look at it. The blood enters the right atrium through the inferior or superior vena cava, and it's the end of the cycle, so it just gets into the right atrium. It goes through the valve, which is called tricuspid valve. It goes into the right ventricle. It goes up through the pulmonary artery and into the lungs and gets all oxygenated. And then it goes down to the left side of the heart, into the left atrium. Now, I didn't realize it, but there's 4 pulmonary veins that put it into the left atrium. So there's a lot of flow there, a lot of pressure on the left side. It goes through the mitral valve and it goes into the left ventricle, where that's the heart, that's the pump, that's the engine for the heart. Goes through the aortic valve up into the aorta and to the body, okay? So those are the names of your valves, and this is the way it should go. Now I'm going to give you a scenario. What if after those little 3 subclavian arteries, off the aortic arch, let's say there's a kink somewhere coming down. There's a kink or there's a narrowing. Blood can't go through it the way it should. So a lot of it's going to flow backwards, right? Kink in the hose. So if it can't go down, it's going to go up. Now, how would you know that was going on? Well, what do we do at birth to all newborns? We check pulses, don't we? We check to make sure that there's brachial pulses, femoral pulses, popliteal. We check for dorsalis pedis, posterior tibial. Now, this condition is called a coarctation of the aorta. This means a co is like a notch or a narrowing. Blood can't get down to the feet. Many times there are no pulses in the feet. I found this once before the physician did. I still feel good about that because I really didn't know hearts yet that well. So I was so excited. Now, how do you make that diagnosis that you know for sure it's that? Now take a blood pressure on all 4 extremities. If you take a blood pressure on the lower extremities, the blood barely got there, right? Because that kink is there. There's no pulse. Blood pressures are lower. But look at the upper ones, okay? The blood is going upwards. It's going backwards and up. These are going to have a higher blood pressure, 20 millimeters of mercury higher than the lower. So no pulses on the dorsalis pedis. You got blood pressures that are lower on the bottom, higher up top. This is coarctation of the aorta. Now, many of these children, we don't figure it out till later on because the kink isn't that big, okay? What would bring them to the doctor? What symptoms? Well, you see those 3 little vessels that go up to the head, aortic, on the aortic arch? You're going to see headaches and nosebleeds in the older kids because of that extra flow that's constantly going there. All right, what would the younger kids see if you don't see it right away? It was not diagnosed. The kid's 3 months old. Well, that blood keeps going backwards from the aorta. Where does it go? Back into the left ventricle. And it fills it up and stretches it. Oh, there's no more room. Oh, I'm going to go into that left atrium. Oh, no more room. I'm going to go back into the lungs and fill it up with fluid. Now I'm in congestive heart failure. Does that make sense to you? Okay. So just think about a kink in the hose. Coarctation is some of those questions that they love to throw on you. All right. So let's look at that kid. And I had a 3-month-old girl who came to me with all of those symptoms, looking just like that. She couldn't eat well. She was tachypnic and tachycardic, and she was not gaining weight. Well, if you can't breathe because you have fluid in your lungs, you're not eating enough, you're not going to grow. And developmental delays because no nutrition, you're going to be cognitively delayed. Fine motors, everything. It's all going to be delayed. Now, these children, one of the diagnosis is, as a nurse, we can give them is inadequate oxygen perfusion because they've got it full of fluid, leading to activity intolerance, right? Now they can't breastfeed, they can't eat, and now this child's going to have poor weight gain. So that all makes sense. You know, that little girl that I took care of, she was in an area on the west coast of Florida, and they don't have a lot of cardiac for children there. And finally, at 3 months old, she came to us on the East Coast, and we found it for her. Now, there was no prenatal history at all. A lot of cardiacs are not, but there was a family history of cardiac illness, and that's part of it that brought it in. Now, looking at a kid, what do you see? Remember, a lot of these are newborns right out of mommy, you know, and doing an assessment, as I said, sometimes the nurse catches it first, because usually the neonatologist, they're not there. So it's usually the nurse who takes the baby, unless it's a high risk delivery, and the nurse is going to evaluate it, and the nurse can make a difference. So if you want to work OB, you should know, you know, a little bit about cardiac, because these are the conditions that you'll find. And many of them, as I said, they're not diagnosed before they're delivered. So they're older. Are they eating? Are they gaining weight? What's their color? Are they bluish? Are they pale? Capillary refills, you know, pulses, all of those, right? Do we hear a murmur? Do you feel that buzzing in the chest or something that's like that? And then you're not going to see things like clubbing of the fingers till later. And I got a picture of that to show you. We're going to look at the chest, look at the belly, and we're going to do an EKG, look at the heart rhythm. You know, we can see ventricular hypertrophies in some of the leads of a 12 lead EKG, which will show you a left ventricular hypertrophy, and maybe that's that coarctation, which means a stretch. Hypertrophy means it's bigger than it should be, which is what coarctation does. And then, of course, listening. Is there a murmur there? What's going on there? So we do an EKG, very simple. And then we're suspecting something, we're going to do an echocardiogram. Now, once we do an echocardiogram and we see something that could be a cardiac congenital defect, we're going to schedule them for a cardiac catheterization. And we're going to do it to diagnose what's going on. Usually it's not an interventional at that point. Usually it's just to get more information to determine what's the best thing for this child to do. Now, electrophysiology studies are for those children, usually older, that they found that these children have intermittent periods of elevated heart rate, like high tachycardias. You know, it could be a 2-year-old that all of a sudden his heart rate goes to 240 and they drop on the floor and pass out. And they found out that it was the heart. And they put them on medicines, and the medicines don't work as good as it should. So what the heart says is, you know, your SA node should introduce a beat. And that's where beats start, right? The sinus atrial node, the SA node. Well, somewhere else in that atrium says, no, I want to work, you know, forget that SA node. I want to work. And that heart rate normally is 240 to 400. So seeing elevated heart rate like that is something that you may see there. So the cardiac interventionalist who's doing the EP studies zaps that place with a laser. And they zap it and it goes away. And we can, instead of being on medicines for life, we can wean them off and they'll do very well. They just zap it, and it's through a cardiac catheterization. I
have a question.
Sure.
They zap the SA node or?
No, the place, the foci that's creating this beat. Because the normal heart rate for an atrium is 200 to 400. It's the SA node that says, no, I'm controlling you. Okay? So it's what we call another foci, another place that says, I'm going to work. I ain't listening to you. And they go and say, all right, you're gone. And they zap it, a little laser, and it works beautifully. They use it on all age, children and adults. So it's very, very successful. So cardiac cath, how do we take care of these kids? Well, it's a normal pre-procedure. It's these children end up with NPO, but we're not after midnight, not like adults. You know, if it's a young newborn, which many of them are, it could be 2 hours prior to procedure because we don't want to mess with their dextrose, because 2 hours before is more than enough, especially on a breastfed infant. Now, important stuff. You get the kid back from cardiac cath. They have put into the right femoral artery and vein big catheters that go up into the heart, and they're able to inject dyes and do whatever else they need to do to identify what's going on, okay? So when they come back, they have a pressure dressing on these children's legs. Now, older children will have a sandbag, but newborns can't have 5 pounds sitting on their leg because it will occlude all of the blood going to the foot. So it's just a pressure dressing. The biggest risk of a cardiac catheterization on infants is blood loss from the insertion site from those catheters. So number one thing you're going to do, check that dressing, because these big holes, that clot could come off, that they, held it to that clot was there, could come off in the movement coming back from the room from the cardiac cath area. And this child could bleed out in minutes, especially infants. So first thing, check the dressing. Now, what if it is bleeding or you see this big dressing full of blood? You're going to put your fingers right above, the heart's over here, and this is the dressing right above it. You're going to put your 2 fingers and push and call for help. Now, what is the treatment? Pressure. You hold it until the bleeding stops, but you want the physician there to see the amount of blood, et cetera, that came out. I mean, many of them need transfusions. It's that severe. Another thing we're going to do is, look at the pulses. They're going to be a little decreased. That's normal. But just document it, and then in your exchange of report, make sure the nurse knows they are decreased from the right leg to the left leg, but they're okay. Vital signs per protocol. Usually when they get there, after I check that dressing, and then, every 15 minutes, an hour for 2 hours, and then every 2 hours for certain, et cetera, depending whatever your protocol is. They are able to take stuff by mouth, and we always will do, they always have an IV because they're sedation for this procedure. But the thing is, the bed, because remember, this is right in the groin where this blood has been clotted, and you don't want to pop that off. So elevate the head of the bed slowly, and do not bend that right leg, because again, that will pop the clot on the area that just had it. And bed rest 24 hours. So these children are hospitalized for 24 hours. We keep that leg straight. We're going to be giving them either PO or IV. We're going to be checking their pulses and their vital signs. And then the other thing we're going to do is check blood glucose levels. Many times in the procedure, they don't get any IV fluids with glucose, and now their blood sugars are 30 and they need to get replaced quickly, or sometimes they got glucose and it's too high. We just need to know where they're starting at. So congenital heart defects. I never knew how many there were until I worked in that cardiac unit, more than you could ever imagine. One of the most common is your ventricular septal defect, and you'll see a lot of the Downs children, whichever number it is, 21, 18, 13, 11, 9. As the number gets smaller, they're worse defects. But whenever you have a suspected Downs child, you always listen to their chest first on after birth, because you might hear that VSD. And you will hear, that's a murmur. It doesn't go, it's, and if you put your hand on the chest, you can almost feel it vibrate on a newborn. So congenital heart defects are either, well, they're getting oxygen around, or they're not. And of course, we know the cyanotic heart diseases are the ones that we have to act on the quickest, right? Remember, as that garden hose, the blood's going to go to the area of least resistance. So if we kink the hose, it's going to go back, and it's going to keep going until it fills up the lungs in a coarctation, right? So we know that the left side, the left atrium, pumps a lot of fluid into that left atrium. Now, what is one of those conditions that we have at birth between the right atrium and the left atrium? Isn't that a foraminal valley? A little hole there, part of fetal circulation. So there is a little connection there at birth. I mean, it closes up shortly thereafter, but it's there. So what's going to happen with the increased pressure coming in from the left side and the blood just getting there on the right side? Well, blood's going to go either through that patent foraminal valley, or if there's an atrial septal defect, it's going to go down into the right ventricle and just be recirculated in the pulmonary system. It's just going to get extra pulmonary blood flow because it's coming back, it's oxygenated blood going back into the lungs, okay? Now, this is another diagram. It's right out of your book. It's a good one. And let me tell you those things you have to know. So I just told you that atrial septal defect is going to have increased pulmonary blood flow because it's got extra blood coming from the left side. Simple as that. It could be because that ventricle has a hole. Very common, right? It's going to go and give increased pulmonary blood flow. Very common thing that happens. Now, we're going to go into a patent ductus arteriosus, and this is fetal circulation. Now, patent ductus arteriosus is a connection that's intrautero during pregnancy. Mom secretes something called a prostaglandin hormone, and it keeps this duct, this patent ductus arteriosus, open, and it connects the aorta to the pulmonary artery. So now we have a connection between lungs and the body. Very important concept, okay? Now, we need sometimes to keep that open when blood isn't getting where it should go. If blood isn't getting to the lungs for whatever reason, you need oxygen or you're going to die, right? And at birth, this patent ductus arteriosus, mommy's gone. There's no more prostaglandins, right? So it's going to close. So what are we going to do? Now, let's say there's no connection between the right atrium and the right ventricle. So the blood comes in, ready to go back and up into the lungs. There's nothing there. That's called a tricuspid atresia. That's a decreased pulmonary blood flow. All right? How are we going to oxygenate that infant? Another one, transposition of the great arteries. You have that where it should go to the lungs is going to the body. And when you would go to the bodies, it's going to the lungs. And they're both going and not connected. You need to connect and give oxygen in there. So what do? Well, we can give a continuous slow infusion of a drug called prostaglandins. Pretty cool, huh? And it will leave it open till we can do our cardiac cath, so that we can diagnose and not rush to do surgery and do it when we have the best decisions made. So it is a great thing to keep open. We're going to go into a little bit more. I've got another slide on that. The obstruction, we've already talked about coarctation of the aorta. I needed to do that one to show you about blood flow. Now, stenosis is a narrowing. There's still blood going through, but there's a narrowing. You usually see it in valves. The aortic valve goes to the body, right? And the pulmonic valve or stenosis goes to the lungs. So if there's a decrease flow, again, there's problems with that. And we can just do a cardiac cath and put a balloon, stretch it out many times, and we can increase blood flow. Now, the one diagnosis that you are going to see on exams, you're going to see on HESIs and on your NCLEX, they love to kill this diagnosis, is tetralogy of Fallot. Ever hear of a tet spell or baby turns blue? Okay, tetralogy of Fallot, somehow you see it as a decreased pulmonary blood flow. Well, most of the time blood flows around and the kid's fine. Then all of a sudden, for whatever reason, there's like a little flap of skin that closes up that pulmonary valve. Blood doesn't go to the lungs. So you don't get oxygen. Guess what happens? It happened to me once at 4 o'clock in the morning, and I went from O2 sats of 100 down to 10. It must have been a minute. This kid went from bright white to gray black. It was very scary. So what do you do for a TET spell? Well, you have to act now because you can't wait for a doctor, right? 4 a.m. in the morning, he's sleeping. I got to go wake him up. You do something called a knee chest. So you take the knees and you take the head and you push them together real quick. What does that do? Well, you've got a abdominal cavity and you have a chest cavity, and that pushing changes pressure, and it takes that piece of skin, opens it up, and the kid starts oxygenating. So TED spells are treated by knee chest. Now, there are older kids who have tetralogy that haven't been diagnosed, or they can't do surgery, whatever reason. These kids on their own can feel this happening, and all of a sudden they'll squat. They'll just sit there and they'll squat. And what did they just do? They did their own knee to chest. Pretty cool, isn't that? And then the other one, as I said, transposition. We need to keep prostaglandins going. The kids do really well. And then the most severe of all diagnoses, and I think the parents on these children always are the nicest, most wonderful there are, is a hypoplastic left heart syndrome. Now, most of those children go through 3 stages, surgeries or more. They're always at the cardiologist, they're always, something always going on with them, whether they're having echoes, EKGs, going for cardiac cath surgery. Well, on Valentine's Day, my Thomas is going to be 10 years post-transplant. His heart ended up so bad that he was almost dying. And he said to his mother at 8 years old, he says, "Mom, it's okay. Tomorrow's Valentine's Day. I'm getting my heart." And then, the mother's heart was like, "Oh my God, this kid." 4 o'clock in the morning, they got called. They found a heart for him. And this kid looks wonderful. And it's a beautiful family of 3 boys. So I'll be waiting to read about Thomas and seeing the pictures on Valentine's Day on Facebook, because they always post it. We're just part of this cardiac community. So anyway, usually that's where they end up. Okay, patent ductus arteriosus. Let's go over it just a little more. Give you some signs and symptoms. How do you know when you have it, etc. Now, patent ductus is there at birth, right? That's fetal circulation. It connects what? The lungs to the body, the pulmonary artery to the aorta, okay? There is prostaglandins that keep it open. That's usually during birth. Usually after birth, prostaglandin's gone, it's gonna close. Sometimes it's open a little longer, but usually it's in a day or two, it's gone. They say it can be up to 21 days. I've never seen it last that long. Now, how do you know this kid is a PDA? Well, you hear what we call a loud washing machine murmur. When you put your stethoscope on, you hear this thing going on. The other thing is, most cardiac kids will be getting arterial lines and central lines, etc., to monitor them closely in preparation for the OR. So we're having a constant blood pressure reading. Now, an infant at birth, and remember, these are congenital, this is at birth, normal blood pressure is 60/40. When you have a kid who has a patent ductus, it's 60/18. It's called a wide pulse pressure. So we know that sometimes, like I said, when blood doesn't go to the lungs, we need to keep it open. So we do that slow, continuous infusion of prostaglandins. What does the prostaglandins do? What is the main purpose? Well, it's oxygen saturation levels, but it maintains cardiac output. So maintains cardiac output, and it also keeps those maintenance of the oxygen saturation level. Now, sometimes, especially in premature infants, These things don't close by themselves. And you don't want to do surgery on these little 28-weeker little infants that weigh 2 pounds or 1 pound. But we can give a medicine, and believe it or not, it's like an IV ibuprofen, but it's called indomethacin. It's an NSAID, and we give it in doses. How do we know it's working without doing an echo and looking? Well, the murmur will go away. You'll stop hearing it, right? Because you hear it when it's open. Also, that pulse pressure that was real wide, you're going to see it coming back together again. And I've watched it numerous times. The blood pressure comes, the murmur disappears, and I think it's one of the neatest things to listen to. You can see the drug working as you're doing it. Now, there's a couple things about blood flows. I left them here for you to look at, okay? Congestive heart failure. Well, that's that coarctation of the aorta. Didn't he go into congestive heart failure right there? We know it's the muscles of the heart can't beat. There's all this fluid going on, and these kids can't breathe. They can't eat. They're losing weight. They're hypoxic. They're irritable, right? You're going to see an X-ray that's full of fluid. So what is our goal? Well, we want the heart to beat better. We want to get rid of that fluid, and we want that heart to pump well and get oxygen back on that child. So what do? Well, this is a case that we would give digoxin to. Slowers and strengthens the force of that heart, okay? Remember, we're going to look at digoxin. Remember, a lot of teaching on digoxin comes from us as nurses. A kid goes home and vomits a dose of digoxin. You tell them, do not repeat the dose. You're going to give it 12 hours later. Now, in a hospital, if they vomit it, you have immediate things you could do. Call the physician. But at home, that's what we tell them, unless it happens more than once. Okay? If they're vomiting more than once and then vomit it, that's when you hold it. But if they vomit, just tell them once, maybe they gag, they choke, something you squirt in the back of the throat, something, then just go on. It's usually every 12 hours. And we're going to give them that IV or PO going home, Lasix, furosemide, just like we do adults. It's the same medicine, but they're going to be baby doses. And that's going to get rid of the fluid. We're going to be monitoring daily weights, aren't we? Daily weights is going to be used, to make sure that that fluid is going away. Digoxin's given just like adults. Apical minute, apical heart rate for 1 minute, usually less than 100, you're going to hold it. You're going to check the potassium, check any drug levels. Again, vomiting is the only sign you see. So if it's more than one vomit, then you're suspicious, not with just one vomit. We want to get that heart beating better. We want those lungs to be clear. When that happens, we're going to be able to eat. We're going to get the nutrition. And of course, we're going to be teaching the parents all about these things that we're doing. Now, as I said, hypoplastic left hearts, they're never going to saturate 100. We get them up to 92, we're good. Usually they're born at 75, even 65% O2 sats. We have to leave it there because that's all they can tolerate for many different reasons, which I will not go into for you because it's so complex. Just know that we can't. They will be low. Now, what happens when you have a low O2 saturations for an extended period of time? Well, the body is really cool. It says, we're not getting enough oxygen here. Let me produce more red blood cells, which are supposed to carry oxygen, right? Supposed to carry oxygen to the body, but there's no oxygen to put there. So it keeps trying to produce more red blood cells. And what happens? You become polycythemic. That's what polycythemic is. You'll have a hemoglobin hematocrit of 18 and 54. Normally, these kids should be at 14 and 52. Their blood is thick and it's dark red blood because the body's trying to just make more cells. Usually cardiac parents are wonderful. They want to learn. Please, help them to understand signs and symptoms. Let them know what's going on. Let them be prepared. I'll let them look at a kid who had just had surgery if I get permission, of course, from the other parents that just had surgery, which they always do in the cardiac world, they do, so they can be prepared what they're going to see on their kid. And again, we are trying to get them ready for home on admission. So again, cardiac cath, what did I tell you? NPO, when they come back, check the dressing, put pressure right above, usually 2 fingers on the little infants, checking pulses, bed rest 24 hours, elevate the head of the bed slowly. They can have fluids and check your glucose. Bacterial endocarditis. This is where you need those prophylactic for dental or anything they're going to do, just like adults. It's an infection of the lining of the heart. Rheumatic fever is when we do not treat a strep throat and treat it properly, or we don't complete the dose of antibiotics. When you get a kid who comes in, their joints are swollen, they have fever, they have a rash, they have nodules, something else called chorea, which is a shuffling gait thing. These kids come in, one of the first questions, has your kid been sick lately? And if they've been sick with a sore throat in the last 2 months, it's probably rheumatic fever. It's due to a strep throat that wasn't treated. So how do we treat this? Antibiotics. Now, one of the worst things about rheumatic fever, rheumatic heart disease, is that it affects valves, usually the mitral valve. Once it's damaged, it will not be able to fix with antibiotics. All the other symptoms go away, but the heart valve will still be damaged. They can have high cholesterol like we do, so we're treating that now. They can have all sorts of dysrhythmias. I've seen 1 and 2 year olds with pacemakers. They had, bradycardia, heart rates at 6, which, bodies can't live at that low. And of course, like I said, tachydysrhythmias, and they're getting, those little areas zapped. Sometimes their lungs are whatever, they've been damaged and they're tight and they don't exchange oxygen and carbon dioxide. And it does happen, and I've seen it. And the last thing that they treated this with is actually Viagra. It dilates the vessels in the pulmonary vasculature, and it allows oxygen and carbon dioxide to exchange. That was developed up in Boston. They found that out a couple of years back. Because if you can't oxygenate, you're going to get short of breath easy. You're going to have chest pain, and you're not getting oxygen, you're going to get dizzy, for sure. Cardiomyopathy, as I said, a lot of times it's viral. Big, floppy, stretched heart, not really working well. Could be due to, as I said, like lupus, could be due to infections, could be due to some sort of metabolic deficiency state. And many of those, just like the hypoplastic left heart, ends up with a heart transplantation. Biggest problem with heart transplants and the biggest cause of death is rejection. Chest tubes are constant in the world of your cardiac. Remember to take it out. Number 1, teach the child what's going to go on. They should be sitting up, not completely up, but a nice sitting there. Medicate them for pain. Tell them it's going to hurt because it will burn for a little bit. You cannot not tell them that because it will hurt. And also take their vital signs before and after and document it. We're now checking all children ages 2 up for blood pressure problems. We found out kids young ages are with high blood pressure, and we know it can cause all sorts of problems, especially damage to the kidneys, right? And then Kawasaki disease. It's another one of these weird viral things. It inflames the vasculature. It's called an acute systemic vascularitis. And what we're mostly concerned about is the coronary arteries. Those vessels get inflamed and can get aneurysms and pop, and they can die. These kids have these hands and feet that are like peeling or blistered. They have a rash on them, strawberry tongue, cracked lips, and glow in the dark eyes. And how do we treat this? Well, this is the only time you will give aspirin to a child. And the aspirin is given because it's like an anticoagulant. It's going to prevent clots, especially in those coronary arteries, right? And we also give intravenous immunoglobulins. It's a virus. It's not antibiotics. Kids can go in shock, and as I said, number one cause is septic shock, and we treat heart rate up, blood pressure's down, decreased perfusion, decreased urinary output, mentation, all of those things, just like you'd see in an adult. So here's your PDA question, and we'll stop. Surgical closure of that patent ductus arteriosus would do what? Remember where it is, a connection of the pulmonary artery to the aorta. And remember that aorta has that left ventricle pumping hard, pumping it out.
Is it D?
Absolutely. Yes, it is. Good job. Because it goes in that left side and goes back right back into the lungs and it washes it out. Good job. So did you get through that? Did I make it clear that you could understand it? It's going to take listening to that again. It's a lot of information, but hopefully I made it in a way that makes sense for you. So let's go ahead and do our Kahoot. Who wants to win today? I think Cameron wants to win today. Or is it Ganna? Ganna going to win today? Yeah? Okay. Mayona likes to win too. So there's 50 some odd of these, I believe. Such many information. It's hard not to put that many questions for you to make you understand. All right, let's get going. Respiratory cardiac, week 5, it goes by quick. A majority of upper respiratory infections are caused by what? Viruses. Viruses is number one cause. That's why you get Tylenol and Motrin and they send you home. Drink plenty of fluids. You walk into a 6-year-old child's room and you stop breathing and does not wake up. What do? Do you know your CPR? Number one, you start chest compressions immediately. And of course, there's a code blue button that you're going to push to as you're doing it, but start those chest compressions. Years ago, they used to say, give 2 quick breaths and then do it, but they found out a lot of people weren't going to resuscitate because they didn't want to touch their mouth. So today we know that just chest compressions work. I'll multi-select. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? A little bit of all of them, right? I said maybe you only see a fever and not eating. You might see a vomit, but sometimes it's very subtle. I think that not eating is the number one that you do see. A multi-select, there's a lot of those today. What do you look for when assessing a respiratory function? Well, we want to know how fast, how deep, if they're labored, if it's easy in breathing, and all of these things can give you the clues of what you really need to do for that child. What would you look for after a child has a tonsillectomy? So remember, they've gone in, done surgery, and they've literally sliced and cut out these big things on the side of their throat. And there's scabs there. And one of the things that we look for if they're swallowing a lot, and the reason is they could be bleeding. Remember, those scabs can still leak and the scabs can come off. So if they're swallowing more than usual, probably this child is bleeding. So you would call the physician. Don't look in there, okay? Because that can create more bleeding. Another multi. Nursing care for a child after a tonsillectomy includes the only thing we're not going to do is spicy foods. But remember that gum helps with those ear pains a couple days out, usually 5 days out. And older children can take it. And make sure we medicate because it does hurt. And remember, the first thing we're going to give for them to eat is maybe some ice chips. We're going to see how they tolerate that first so you don't create a lot of bleeding. Another. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? So it's the same thing, different words, tracheobronchitis or bronchitis. Remember, it's dry, nothing comes up, you can't sleep. And one of the recommendations is some sort of cough suppressant to help them sleep at night. Very annoying. Another multi. What signs and symptoms would you see in a child with otitis media? Well, what is an otitis media? Well, otitis media is an infection of the middle ear. It's very painful. Remember, your priority is medicate for pain. You sometimes will see that it's already burst and there's a drainage, loss of appetite, and sometimes there are no fevers with ear pain with otitis media, believe it or not. Never high fevers. The monthly immunization for RSV, respiratory syncytial virus. We use it for our immunosuppressed and our very small children, maybe your premature children, your cardiac children. Because of all of the mucus that's there, it's called Synagis or Pavizumab. Very good. HIB is your hepatitis, and Humira is for like rheumatoid arthritis. All the following are signs of early respiratory distress in children, except. And if you see this, you better get this kid to the trauma room because this kid's going to crash. This kid's going to require intubation and now. And that's bradycardia. Respiratory distress, tachypnea, tachycardia, for sure. They're working so hard, they're diaphoretic, yes. And they're restless because they're hypoxic, okay? But bradycardia, it's the last thing that you see. That's danger. A 4-year-old child's been taking meds for asthma and they're still wheezing. What information is important to ask? Like, why is this happening? many times the child's not using the MDI and they can't push it and inhale it, or they lost the MDI or it broke, whatever. So that'd be a very important question. Or you're going to be doing all this crazy treatment and it's all because they didn't get the medicine. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? What you're going to see is those retractions and restlessness because of the hypoxia that's going on. Respiratory rate of 25, that's absolutely slow, so we're fine. O2 sats, that's great O2 saps. Pulse of 100, abdominal breathing, this kid is still calm. That's not any sort of distress. Signs and symptoms of asthma include all except so they have the hacking cough, they're going to be short of breath, they're going to be wheezing. But what happens with asthma is they can get air in, they can't get it out. For instance, croup, right? Inspiratory stridor, they can't get it in. They could blow out all they want. In asthma, you'll see them push and go, and you'll hear this wheeze as they're trying to push air out. So remember, asthma is that expiratory wheeze and prolonged, okay? In croup, you're going to see inspiratory stridor. That's the difference between those two. Signs and symptoms of congenital heart disease include all except So congenital heart disease, they're working so hard, they're not gaining weight. Excellent, good job. Point taken, good. What should you not do to children diagnosed with croup and epiglottitis? I mean, anything upper airway. Remember, if you look in your mouth, you're going to create more swelling. So you're not going to look. I mean, you can do an IV, you can do an X-ray, you can have, oh, please have the parents hold them actually, but don't look in there because you can create more swelling and you don't want that. The epiglottis is what? What did I tell you about that? Epiglottis, where is it? What does it do? Remember, it's that leaf-like structure which covers the larynx when you swallow to prevent aspiration. And when that swells, you can't get air in. Inspiratory stridor, medical emergency, drooling, tripod position, muffled voice. Treatment for infectious mononucleosis. The kissing disease. Just a kissing disease, no big deal. So no contact sports. Mononucleosis is an Epstein-Barr type virus. No antibiotics. The big thing is no contact sports. Protect that belly, the swollen spleen or liver or both. A multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? I mean, we do these questions for many reasons. We do it for patient placement, where do we put the child? And it's also prevention for you and others as we're doing any of these admission questions. I mean, we want to know how big the fever is. Yeah, okay. We're not going to do anything different, but we want to know medications. When did you give them? But immunization status is very important. I mean, is this kid who has one of those very contagious things like pertussis? Because they could just show, just like what that question said. What is cystic fibrosis? So you do have your case study on cystic fibrosis, and a lot of your questions you're going to be able to answer just by today's lecture. So it's lungs and digestive system. They're both, and they're both clogged. Remember, you have the pancreas insufficiency, so we give pancreatic enzymes before your snacks and meals to help with digestion, because if not, you're going to have a child not getting proper nutrition. What is the greatest risk for an infant having a cardiac catheterization? 2 big tubes are being put in the right femoral artery and vein to go in there and look, see what's going on. Remember, we do a cardiac cath after an echo says, yeah, there's something wrong here. Let's go and investigate. And our biggest problem is hemorrhage. You know, the reaction to dyes, dysrhythmias, pulses, well, they're going to be decreased for a little bit, but they come back because it's just a little swelling due to the irritation of the cannulas. How is cystic fibrosis identified? What did I tell you the parents to do? So sometimes it's newborn screening, but it's sweat tests, and it's very simple, and they're just looking for that sodium. Remember, these kids are losing salt like crazy. A multi-select. What is included in the plan of care for a child with cystic fibrosis? So we have to take care of the chest, and we have to take care of the digestive system. Also, they need high protein in their diet because they are losing other nutrients. Again, it's not a low sodium. They're losing salt in their sweat. They need as much sodium as they can. What is a drug of choice for the pharmacological closure of a PDA? So remember, a PDA is from fetal circulation connecting the pulmonary artery to the aorta. It's kept open by a hormone secretes called prostaglandins. And sometimes after birth, it doesn't close. So we use indomethacin, which blocks the production of this prostaglandin, and it closes the PDA. Okay, does that make sense now? What is not a feature of tetralogy of Fallot? Now, tetralogy is all right-sided stuff. I mean, some of the other things here is you're going to have a heart that every now and then is going to have a blue spell because there's some sort of pulmonary artery stenosis or a flap goes over it. There's usually a hole between the septums and the ventricles, so a VSD. Because sometimes that blood flow can't go into the lungs, it stretches that right ventricle, right? It's nowhere to go, so it stretches it and then goes backwards. But also then somehow because of the VSD, it sort of pushes over the aorta. They call it an overriding aorta. Those are 4 things that you see with a tetralogy of Fallot. What medication would you hold on an infant that is vomiting? The vital signs are 98, 88, 32, TPR. You know, all of these medicine are adult medicines. They all can be given to children, newborn infants. They just give them the milligrams or micrograms per kilogram. And yes, vomiting, you think about digoxin. Good job. And you're going to send them home saying, Mom, he vomits when you give it to him. Just don't give it to him. Wait till the next dose and give it. And then you'll further say, if he continues to vomit, then call a physician. What would a child with tetralogy of Fallot not gain at normal rate? Why aren't they gaining weight? Any congenital heart defect. And remember, tetralogy of Fallot is a cyanotic heart defect. Inadequate oxygenation, you don't have oxygen, you can't breathe, you're not going to eat. All are examples of cyanotic heart murmurs, except which one? It's actually two here, and I don't have it checked. Aortic stenosis, it's still flowing, and ASD. Remember, that's increased pulmonary blood flow, so I apologize. That should also be there too. That's not cyanotic. What is the most common cyanotic congenital heart defect? Most common. So what I told you, you need to know because you're going to see it everywhere. And that's your tetralogy of Fallot. PDA, no, everybody has a PDA when you're born, but it's not a heart defect, okay? Truncus, hypoplast, all of them are defects. Tetralogy, most common. Nursing care following a cardiac catheterization. So the biggest thing is check that insertion site for a hematoma or for bleeding. Biggest thing. You're not going to elevate that bed, head of the bed that quick. You're not going to touch that leg, keep it straight, and they're bed rest 24 hours. A multi again. Nursing education for cardiac catheterization include all except you're not going to bend that extremity and you're not getting them out of bed. Good. 24 hours bed rest. Which information is most important when rheumatic fever is suspected? Like, what do you want to know? As in, what causes rheumatic fever? You know, in this course, you're going to find two different things, you know, that can cause problems because of this. Strep throat causes rheumatic fever, and it also causes something else, and we're going to find that out in week 8. Signs of shock in children include all the following except. Remember, shock is shock. Adults, children, it don't matter. It is shock. They're going to have hypotension, right? Not hyper. Their blood pressure is going to be low. Their heart rates are going to be up. They're going to be altered mental status. They're not going to have oxygen, poor capillary refill, no urine output, all those things. Which of the following best describes the pathophysiology of Kawasaki disease? So it's a multi-system vascularitis. And the big thing is the coronary arteries and aneurysms, which could cause death, of course. How do we treat it? IVIG and aspirin, right? Only time aspirin. No, multi. A clinical manifestation of Kawasaki diseases. It's basically a little of everything, but it's a different type of rash. It's not those big demarcated rashes, those little petechiae looking little rashes. What is the treatment for Kawasaki disease? Aspirin and IVIG. Absolutely. We're going to help the immune system, and the aspirin is to prevent clots. Good job. Which of the following is the most common cause of shock in infants and children? Infection, sepsis, always common. Very good. What are the defects associated with tetralogy of Fallot? Now, when you think of tetralogy again, remember it's all right-sided. And then you could sort of pick this out from there. Very good. Yes, pulmonary stenosis, VSD. The aorta is actually called overriding, and then the right ventricle is stretched. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell? We know infants do knee chest, right? We have to do it for them because it changes the pressure between the abdomen and the chest. It works. And it's called squatting. They just all of a sudden they squat and it changes that pressure by themselves. Transposition of the great arteries. What is that? What great arteries are transposed? You know, with this condition, you have the pulmonic and systemic circulation. They're not mixed. So we need to keep give them oxygen. Sometimes we take and make that foraminal valley between the two atriums, open it bigger to let blood flow through there. And then we do something called an arterial switch, which is we just switch over and put back down these vessels in the heart, and it works. Which of the following is not an intervention indicated for a TGA? Basically told you what the treatment was. You know, this is a big deal, transposition. I mean, you've got two separate circulations, pulmonic and you have systemic. They are not matching. Oral nothing is going to work on this child, okay? It is IV prostaglandins. We're going to do that operation sometimes a week later, or sometimes we need to make a hole bigger to make some more oxygen going around. A multi-select. Why is prostaglandins given to a child with transposition of the great arteries? What is prostaglandins used for, right? We know it's for oxygen and it maintains cardiac output. It is not an antibiotic for anything, okay? All it does is keeps that vessel open. It oxygenates and lets the heart work. What is the purpose of giving indomethacin to a neonate with APDA? What does indomethacin do? Indomethacin is going to stop prostaglandins and it's going to close the PDA. It's a chemical. And we can hear that murmur disappear. And we also can see that pulse pressure get narrower. It's pretty neat to watch. Where is a PDA? I've said it at least 6 or 7 times already. What does it do? Where does it connect? We know it's fetal circulation. It connects the pulmonary artery to the aorta. So we have stuff going from lungs systemically. That's how I remember it. Lungs to systemic. This heart defect allows blood to pass from the left ventricle to the right ventricle. So if you're connecting the right side to the left side, it's going through the septum. So if it's through the ventricles, it's a VSD or ventricular septal defect. If it's connecting the right atrium to left atrium, it's an atrial septal defect. Very simply said. Another multi. What is a sign of digitoxicity in infants?
That's the heartbeat of a heart.
It's going to be nausea, vomiting, and it's going to be that lower heart rate. Tell me, how is an infant going to tell you they're seeing yellow spots? An adult would, not an infant. And digitoxicity has nothing to do with an infection. What is congestive heart failure? What does that mean? What was the question? I'm sorry, what was the question? I was talking to my grandson.
Congestive heart failure.
It's when the muscle gets damaged and cannot beat that well, and fluid will build up in the lungs. Thank you. I apologize. Left-sided congestive heart failure causes what? So remember, the left side kink in the hose, that heart's not working well. What's going to happen? It's just like coarctation. It's all up into the lungs, all of those lung things, shortness of breath, coughing, and fluid. Good. After a heart transplant, what's the leading reason children die? So it is rejection. It's not failure. It's not infection. Remember, rejection. The body said, I don't want this heart. It's not mine. A multi-select. Signs and symptoms of rheumatic fever include So you see a little bit of everything, and you also see that rash. And remember, there's also that heart valve problem. If it's damaged, it's not going to correct it. We treat it with antibiotics, and all of these things will go away except heart valve damage. A multi-select. A child's about to have the chest tube removed. What should you do? So chest tubes are very common in cardiac. They're going to have one if they have surgery, and they have to come out. Now, I've worked both adult and I've worked children's post open heart surgeries. So I've had adults I could talk about, and they tell me removing it burns and it hurts really bad. So explain it on their level. Make sure you medicate them for pain. I mean, this is number one key. And be honest, tell them it will hurt, okay? And of course, you can do vital signs before and after. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What's your priority? You need to have this child coughing, or they're going to end up with pneumonias and more complications. So how are we going to get them to expectorate secretions? Well, you're going to medicate them for pain, and they're going to be able to do all the other stuff. You don't give them pain medicine, they're not going to do it because it hurts. How would you feel if you just had, abdominal surgery? They want you to get up, get out of bed, do incentive. You say, no, it hurts. You'd probably be crying. An infant of 3 months has a fever of 103.6. What would you use to medicate an infant less than 6 months old? What does an infant get? And it's only Tylenol. We do not add ibuprofen until 6 months old, okay? So it's only Tylenol, 2 to 6 months. A newborn infant's assessed, and the nurse finds very weak lower extremities. What should she assess next? What do you think that means after lecture today? Decreased or no extremities on the lower. There's no pulses. What are you suspecting here? You're expecting maybe it's coarctation of the aorta, right? Do 4 extremity blood pressures, the uppers are higher, the lowers are lower. Yep, you probably got a diagnosis there. A multi again. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? We think only of somebody who's on bed rest for long periods of time is the elderly or adults. Well, children can be in bed for months for many different reasons. So we have to do a lot of things to prevent complications. So we are going to, make sure that they do incentive spirometry. We're going to keep that child dry. We're going to use whatever diapers or pads. I use their toys to prop them over, pillows, blankets. Elevating the head of the bed, does that prevent? Maybe, maybe not, but the other stuff for sure. How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? So on infants, we're going to use an oxy hood. Well, let me turn this around and say, how can we do it easily tolerated and accurately monitored for a toddler? Well, they're not going to tolerate an oxy hood, are they? That child would get a little nasal cannula, and that would be tolerated. No mask, nothing covering their face. They don't like that. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, their lungs are petri dishes. They're just full of mucus. And we're doing incredible stuff, right? To keep these lungs moving. So deep breathing, chest physical therapy, exercise, emulating PRN. No, this child needs to be up 4 times a day minimum. And then aerosols, whatever we have to do, we need to keep those lungs open or they're going to fill up, they can't breathe, or they're going to get infected. A multi. Children with cystic fibrosis require pancreatic enzymes with meals and snacks. What teaching should be done? What are you going to teach these parents and even the older children? Everything. Take them right before the meals or the snacks. You can sprinkle it on the food. You can use powder, but make sure they rinse their mouths. And again, don't forget to increase doses as they get bigger. What cardiac defect is when there's no valve between the right atrium and right ventricle? I'm going to ask you, what valve is between the right atrium and the right ventricle? This would be a child that would be placed on prostaglandins to keep that PDA open because nothing is going to the lungs. So it's called tricuspid atresia. Atresia means absent. There's nothing. Stenosis means there's an opening. Some blood is flowing. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess on that child? You know, what's going on? You need to do an assessment. Something's happening here. Probably going into congestive heart failure. Yes, breath sounds. Good job, guys. Let's see how we did today. Number 3, Linda. Good job, Linda. Number 2, Elise. Good job, Elise. Number 1, Mayona. You did it. Number 4, Morgan. And there you are again. I see you're up on the 5. What I want you to do is please go to your modules, go to your quiz number 2, and I want you to open it. And once it's open and you have access, you may start your quizzes. I believe you've heard everything today. Anybody has any questions about material today, need more tutoring, just let me know. Thank you, guys.
Professor Bogart, I have a quick question.
Please put it in the chat. People are testing.